I'm Dr. Amber Klimczak.
And we are
Two Peaks in a Pod.
Well, hi, everybody. Welcome back. I just want to take a minute to brag to everybody about how amazing you are.
I can't imagine why.
Yes.
I just pulled a dirty sock out of my purse.
Yes. Go to her Instagram to see what she keeps in her purse. That was a spoiler alert, I guess. But today was a historic day at Peak Fertility. So Dr. K has done so many embryo transfers before, but today was her very first one here at Peak Fertility, which was so exciting.
So excited. All the girls were so pumped for today.
Yes.
Our patient was excited.
Yes. And I got to be the ultrasound person. I was holding the ultrasound, and you guys, like, Dr. K has the smoothest hands. It was the most beautiful transfer I've ever seen.
No, it was
it was beautiful.
It was because I have Dr. Reed scanning. Normally we're trying to kind of look ourselves and everything, so I was spoiled today.
I told her there should have been like angels around us saying, "Oh," like it was just so beautiful. So we are just really hoping that this works for our patient, and wishing her the best of luck.
Yes, hopefully she's out there listening. She knew that she was the first one at our facility, so she was really excited.
She made history, and then first of many, many more to come. So
yeah, very, very good day.
Yes, so good job. Okay, so I wanted to go over a news article together that my patient sent us, and it's our favorite topic, friends. We love the show Friends.
Yeah.
As you told me last time we filmed, you and Jennifer Aniston are best friends, right?
Yeah. She's not aware. But.
Yeah. And then Courteney Cox and I feel like Courteney Cox and I have a more similar personality. Do you think so? I'm like, I like to be organized and clean and kind of all those things.
Totally.
But Courteney Cox had opened up publicly about some of the hard things that she went through on the show. So I just wanted to read this to you. So it says, Courteney Cox described how she suffered a heartbreaking miscarriage while filming Rachel giving birth on the show, saying in the middle of that, it was so terrible having to be funny.
Oh my gosh, that is really hard.
Yes, and I think probably none of us knew that was happening or going on at the time. And I mean, she's an amazing actress. I mean, she just really covered that up really well, but that's so hard. And I think we see that all the time. Mm-hmm. We see so many professional women that are having to go out and do their jobs in the middle of potentially devastating information that they may have just gotten at the doctor's office.
Oh, yeah. Yeah, I've definitely heard of this, like female physicians where you're on your shift and you're having a miscarriage and you just have to go on seeing patients. I've heard stories actually from 2 different people like that. I mean, it's just terrible.
Yeah, and probably really close to our heart is a lot of OBGYNs that we see as patients themselves. And imagine they're in the middle of a miscarriage and then they're going to do ultrasounds on their patients where everything is great. And of course, they're so happy for their patient, but then how can you not feel just, it's almost cruel to have to be in that position. Yeah.
And it's interesting. I thought I knew something about her going through fertility treatment or something, because I remember when she was filming for Friends, she and Chandler have their fertility struggles and they end up, I think, adopting twins. And I believe someone said that it was sort of representative of what she and her then, what was her husband's name? The guy that was...
he was the guy on screen.
Yeah, they met on screen.
David Arquette.
Yeah. I think they went through fertility treatment, maybe.
I think so. I think they did IVF, if I remember correctly, too. We'll have to go back and look at some of this older stuff. But yeah. And, I think that's why Dr. K and I were always just trying to be cognizant of where anybody could be in their life. So, for example, that's a big thing for us. When you go to really any other fertility clinic, you walk in and you see pictures of babies everywhere, right? But the feedback that we've gotten from patients is that really, although it's meant to provide a lot of hope, that it can actually be hurtful and triggering to you because you walk in and you see, oh, well, everybody else has these babies and that's never going to be me. Or imagine you did fertility treatment with us and you had a miscarriage, we diagnosed you, and you walk out in our hallway and see pictures of babies. Like, so that hard. Is just so traumatic, really. And so that's something that you and I have both made a huge effort on, and just saying, yes, we have lots of success stories and everything, and those photos that we have of our patients are so special, but we do keep them in a special box away because we don't want to be causing any, stress or emotional issues with our patients that are seeing us in treatment.
Definitely. And I know I felt that way when I was going through it. It's really, it sounds terrible to say out loud, but it's so hard. Even like avoiding Facebook and Instagram when I was going through, you know, it's hard. You know, you just see, and you kind of tend to be in that time of your life where all of your peers seem to be having a baby. You feel like the whole world is just pregnant. Oh, I just went off my birth control and I got pregnant, you know? And I just was like so frustrated to see that. And it sounds bad to say it out loud. I mean, I was always so happy for my friends, but I can definitely understand seeing baby pictures, or even like, I think there was like nursing pictures in the hallways where I would go for fertility treatment. And I just remember being like, this is so bizarre. Like, I don't want to see this. So I definitely, but we do have to get pictures hung.
Maybe that's an easy way of us not having to put any art right now.
Right now we have no art. We definitely are careful about it.
We don't have anything. No art is better than art that would upset somebody. So we'll get there eventually.
Definitely.
Well, I figured since that kind of brought up a good topic of miscarriage, let's go ahead and talk about miscarriage. First, I would say that unfortunately, miscarriage is pretty common. And they say that maybe about 25% of miscarriages in general, 25% of pregnancies in general can result in miscarriage. And I think that means that if you haven't had one yourself, you probably know a friend or a family member who has been through this before.
Right. Absolutely. And, you know, not that people always share that, but even if you don't know someone, you probably do. It's just that they, you know, haven't been open about it.
Yeah. I think one of the things that may be helpful to just kind of bring up too is, let's say you are a family member or a friend of somebody who's going through a miscarriage. I think it's nice to go over some things on what not to say to somebody going through a miscarriage, right?
Definitely.
Because what I've heard from a lot of patients is that well-meaning friends and family can actually make them really upset too with the words that they choose. So I'll kind of throw one out there, and maybe you can let me know if you know of any that you've heard. But sometimes people will be told, well, that must have just been meant to be.
Right.
Very hurtful, right?
Yeah. And because to them, that pregnancy was meaningful, you know, and it doesn't matter how far along you are. I think even if it's really, really helpful, you know, it's really, really hurtful to hear, you know, like you're attached to those 2 lines on the pregnancy test, you know? So it doesn't matter even if, you know, someone's saying, oh, it was an early loss, it was meant to be, you know, things like that is so hard to hear.
And then another one sometimes I've heard people say is, well, I have lots of kids. You can just borrow one of mine. I mean, no. You know, like I think maybe they're trying to make the moment lighter and make them laugh, but not the right thing to say.
Yeah. Oh my gosh, definitely.
Have you heard any that?
I hear a lot about, well, you know, you just relax, you'll get pregnant, you know, you'll get pregnant on the next one, just relax, don't stress, you know, all that. And I just know my patients that do not like to hear that, you know, because they're as relaxed as they can be. They're like, hey, I'm like taking hormones and medications, and we finally got a positive pregnancy test. It's hard to just say, oh, okay, I'll just relax. There's just a loss. I mean, it's not just a loss. I mean, it's really painful. You know, I feel like, I don't know if you were like this, but as soon as I saw 2 lines on a pregnancy test, I was like, you know, 10 months in the future. I'm like on Pinterest. What's the baby room going to look? Which cribs are trendy right now? Like, you know, so, and I don't think, you know, especially even like partners sometimes, like, you know, my husband didn't always understand like what was going through my mind, you know, so we women were planners. You know, your mind's always like 1,000 steps ahead. And so then it's not just like, okay, let me backtrack, you know, okay, that's not going to work out. It's like, let me like reel in my dreams, like from distant future. You know, I was planning to have my kids this amount apart, you know, maybe you've already had one child and you're like, oh, I wanted them to be exactly this amount of years apart. Like all of this is planning that we do. And sometimes you don't even think about the fact that your brain is planning it, right? Until you actually have the you know, dream taken away. It's really hard.
I did want to touch on why sometimes that statistic surprises people, because they say, wow, 25% of pregnancies can result in miscarriage. But I think that's because maybe a large portion of them weren't necessarily even recognized by the patient.
Right. I like the studies where they've tracked women's urine and, women who weren't necessarily trying to conceive, and they just followed to see how often they would pick up the pregnancy hormone, which is HCG, in the urine. And what they found was striking, like how often women were having, biochemical pregnancies, not really realizing it. Maybe your period comes 5 days late that month, you know, but our patients are trying to conceive. So like they're taking their pregnancy test exactly on the day that it's supposed to be positive, and then they're picking it up, So I do think it's probably even more common once you start looking for it, paying attention.
So if we have a patient who has had their first miscarriage, let's just kind of touch on what the most common reason for a first miscarriage would be.
Yeah. So I actually think this is a little bit liberating, and I do always go over this with my patients. And that is by far and wide the most common cause of a miscarriage is abnormal genetics of the baby or the embryo. And so just the way the chromosomes came together, usually, a lot of times it is maternal pulling apart, but also can be paternal. And it's just that we're missing, or we have an extra chromosome. And that combination just makes it such that it's incompatible with life. And it's sort of your body's way of taking care of you not having an abnormal pregnancy, or ultimately very, very sick child that maybe doesn't survive even a few days. So I do think that mindset, I think, does help a little bit to know, okay, like this was nature's way of protecting,
Nature is amazing, but it's not perfect. And when that egg and that sperm come together, sometimes nature makes a mistake and it results in an embryo that is not normal. And in most of those cases, an embryo that's not normal won't usually stick, but sometimes it does. And in the vast majority of cases, it ends up causing a miscarriage. And I think it's kind of interesting these days, because if I think back to maybe even 10 years ago, I would tell a patient, hey, that usually accounts for about 70% of miscarriages, is that the genetics were abnormal. But still, as a patient, you can't help but wonder, but what if I was in the 30% that it wasn't caused? And one of my favorite tests that is now available is that if you are far enough along that you can submit some miscarriage tissue to us, we can actually send it off to a company to do genetic testing so that we can try to get an answer, which is really nice.
Right. Yeah. So that's the microarray test, in case anyone's kind of curious about that. Maybe you want to ask your doctor if you're going through it. Microarray is usually the best test for that, to look at the products of conception. And the other really interesting thing, I know we're not really talking about this, but we do a lot of IVF. We do embryo transfers. We test the genetics of the baby or the embryo before we transfer. And of course, if we're doing genetic testing, we're going to transfer a normal genetic embryo. It has a full complement of chromosomes. Well, we did studies where we actually looked to see, okay, even an embryo with normal genetics, maybe it implants, but it ends in an early loss. Still, those pregnancies, what we found on the microarray is, small genetic changes that weren't picked up on the initial testing of the embryo. These are things like microdeletions, small changes on the chromosome where we didn't have enough cells and expansion in order to pick it up when we tested the embryo. But once the pregnancy develops and goes further along, we're able to identify them. Because I think that's another really frustrating time to have a loss. You go through IVF, you do genetic testing of your embryo. You're in your mind, you're like, okay, I have a normal genetic embryo. I'm going to have a really good shot of this making it to a live, healthy baby. And then you have a loss, and you really have that question mark of what caused this? What could go wrong? And still, genetic changes are present there that we're picking up on. We're just getting better and better at identifying them.
Yeah, I think that's a great point. And whenever we're doing genetic testing on an embryo, the embryo is so small. So the sample that they take from the embryo is usually only about 4 to 5 cells, or
5 to 10 trillion.
Okay. So that's just a teeny little sample, because you don't want to take too much sample, because then you could potentially harm the embryo. So it's this teeny tiny sample, and that's why they're really only mainly able to tell how many chromosomes does each embryo have. But each chromosome has thousands of genes on it, and our technology is not to the point where it's checking every single gene on every single chromosome. And so even when we say an embryo is, quote, normal, that is a bit of a misnomer, because what we're really meaning is just it's the normal number of chromosomes, but there may be smaller gene mutations or smaller deletions or duplications on the chromosomes that we can't see with that kind of testing. But the reason you can see it when you do this testing on the miscarriage tissue is instead of that just tiny little sample, you usually have plenty of cells to be able to send off. And that's why they're able to get more complete information. I will kind of just add in here that the standard medical recommendation is usually not to offer this kind of testing for somebody who has just had one miscarriage, but this is kind of where I disagree with the medical field on this. I think from the medical field's perspective, they say, well, we already know most of those miscarriages are going to be caused by genetics. There's not a reason to test. But from my point of view, I'm like, look, a miscarriage is devastating. And I really think every woman has the right to know, or at least to try to test if she can.
Right.
And so, but because of that, this may not always be covered by insurance. And so you might have to do a self-pay price with the company. But the cost has really come down a lot. Maybe 10 years ago, the cost might have been thousands of dollars. The company we happen to use is roughly around $350. And to me, that can just be so worth an answer.
Absolutely. And, I don't know if closure is the right word, but something like that you kind of get from your, like, okay, like I at least have a reason.
Yes.
Something, because otherwise you just sit there wondering.
Yes. And you've probably seen this. I feel like as women, we always blame ourselves.
Always
Overthinking things. Did I lift something too heavy? Is it because I took a Motrin when I didn't know I was pregnant or something, right?
Right. So I do think that offers like just a little bit more peace of mind. Okay, you can't do something and change the genetics of the fetus. It's nothing that you did or didn't do to change those genetics. It was predetermined, and we really don't have a lot of control over it. So, but I offer anyone that I'm going to do a DNC for. DNC is a procedure that we do often when you have a miscarriage and the products of conception are still inside the uterus. We do a small procedure to remove it. Any patient that I have to do that for, I offer them this testing. I think that everyone should be offered it. And sometimes you don't have the opportunity for that. Perhaps you have a loss before, we can do something to collect the product. So it's not always an option for you, but typically if you're having a DNC, it is.
Yeah. And that's a good point too. So let's say you are miscarrying, you're not going to do a DNC, but you still want the opportunity to test. And so what you can do is you can get what's called a urine hat from a pharmacy like CVS or Walgreens or whatever, and just put it on the toilet. And then every time you go to the bathroom, you're kind of looking to see, hey, do I see anything that could look like miscarriage tissue? You can save it in a Tupperware and put it in the fridge and bring it to us, and then we will send it off. Now, sometimes they can give us an answer and sometimes they can't, but sometimes it's really just worth the effort, at least for somebody to, again, just try to get an answer.
Absolutely. Absolutely.
So we talked about what causes the most common cause, but then we have this 30% of, okay, what else could it be? And I think sometimes that's where we're seeing things that can happen in women who are having recurrent miscarriage. So first, I just kind of wanted to bring up the history for recurrent miscarriage. It used to be that you had to have 3 miscarriages before a doctor would be willing to do any testing or potential treatment. But fortunately, over time, they've decided, hey, we're not going to make somebody wait until 3. Maybe let's just offer testing and treatment after 2. So I think that was a really positive direction that our field has gone, right?
Absolutely. Yeah, absolutely.
And I think I wanted to just touch on too, you might see some differences on what people consider a miscarriage to be. And I will say this is again where there's like the textbook answer and then there's my answer. So do you want to touch on that a little bit?
Yeah. Okay. So traditionally, when we're talking about recurrent miscarriage and when we should initiate a workup to investigate, it really should be a clinical miscarriage, not something, there's miscarriages that are called biochemical, meaning you just had the rise in the HCG level, but it was never to the point where it was a gestational sac or anything recognized on ultrasound or further along into the gestation. And so you would kind of get to that point and then initiate the workup, because that's where this testing and research had come from, right? Not by looking at biochemicals or early pregnancy losses.
Yeah. And so this is one where, again, I kind of disagree with the medical field. I've just kind of learned over the years when a patient's, getting pregnant, even if it's early on, even if we never saw a baby, if it's not progressing, I just feel like I can't help but wonder why. What is going on here? Why are we having this super early losses? And so for me personally, and I will say this is different from probably most physicians in our field, is even if somebody comes to me and says, I've had 2 or 3 biochemical pregnancy tests or pregnancy losses, then I am usually offering a workup. But just didn't want to be confusing to listeners out there if you're like, why hasn't my doctor done this? They're not wrong.
Yeah.
They're more right than I am. But that is why you'll just see changes in that as well.
Yeah. I've definitely seen a wide variety of practices with this. I used to practice with a bunch of doctors,
That's
25
true.
doctors,
Yeah.
and I saw people that would initiate a recurrent pregnancy loss after a workup after biochemical pregnancy, certainly. And then I saw other people that were much more extreme. No, it has to be 3 clinical losses, I think, but I kind of fall somewhere in the middle. And it's also, it's really individual, just like everything you and I do. I think that's what makes us really different.
Yeah.
We really listen to our patients.
Yes.
It sounds obvious, but like every patient really is a pretty good historian about telling us about their losses. And sometimes there's something that a patient will say that makes me more suspicious that it may be something else going on, and that may probe me to want to do a loss workup or recurrent pregnancy loss workup.
Yes. Okay, so I figured let's go ahead and start talking about some of the causes and some of the testing that we do. So let's maybe start with the first one, and I would say genetics, which is kind of odd because I know we talked about genetics before. This is what can confuse people. Do you want to kind of talk about?
Yeah. So we do genetic testing of both the patient and her partner. And when we say genetic testing, we mean of them, okay, not of the fetus or the embryo. And what we're looking for is, do they both have a normal complement of chromosomes, 46XX, 46XY for a male, or do they have something called a translocation that may be coming together when the chromosomes arrange in the baby and ultimately causing a loss? A translocation, it's sort of easy to understand. If you've ever seen chromosomes, they kind of look like, they put them on karyotype and they look like an X. Probably people aren't really watching our video, but they're lines, okay? And so you break off a piece of one of them, sort of like breaking off a stick, and then it can go and attach onto another chromosome where it's not supposed to be. And so when those chromosomes are pulling apart and arranging in the fetus, you can get an extra or a missing one from that piece being moved around, and that can end in a loss, because just like we talked about, the fetus, if it doesn't have a normal set of chromosomes, it's not going to have the capacity to keep going and generate a normal pregnancy. So we're actually testing the parents, maybe you and your partner, to see, do you have anything like that going on? We're testing your, what we call karyotype or chromosomes.
Yes. And we think that this type of abnormality accounts for about 5% of patients who have recurrent miscarriage. And one of the great things about finding this out in somebody is we do have treatment for it.
Yeah, absolutely. I want to mention something that my mentor always taught me, that really the patients where you end up seeing this the most, he always said the most common scenario is actually that they have one child at home. Then they're coming to see you and they're having recurrent miscarriages. So again, this is one of those things when I'm listening to my patients and I'm really paying attention to their history, I'm like, okay, they have a child at home and now they're having recurrent miscarriages. So it's not necessarily someone who presents first thing and isn't able to get pregnant. It may be someone that already had a child at home because the way the chromosomes arranged that time ended up in a live, healthy baby.
Yes. And so the treatment that we could consider for a patient like this to reduce the risk of having another miscarriage is that we could have them do IVF with testing of the embryos to make sure that we're selecting an embryo with normal chromosomes to be able to place and help them get pregnant too.
Yeah.
So
it is kind of nice when you find something like that. I
think, it's, that's what we say. Information is power. And I'm sure in that moment, it never feels good to get that information. But then when it's something that you can, that's actionable, then it definitely feels good to know your next steps are guided well.
Absolutely.
Yeah. Okay. So next, I wanted to touch on anatomic reasons. And I will say this is one of the most common that I've seen. And it's funny because it's a similar scenario that you just mentioned, which is sometimes I have a patient who's had a child And now they're struggling with recurrent miscarriages. And I found a lot of times inside of the uterus, they may have inflammation or polyps or things like that that are hiding in there. Have you seen that too?
Yeah. I mean, or, you know, even more commonly with losses, we see septums, things like that just haven't been found before.
Yeah.
So even someone with a septum may have delivered previously and not known.
Yeah. And sometimes I think this is confusing for patients because a patient may say, well, I've had tons of ultrasounds and they've all been totally normal. How could this be the case? And here's the thing, polyps and inflammation and scar tissue can hide in your lining, and we cannot typically see it unless you have, and if y'all listen to prior episodes of mine, you know this is my favorite test, a saline infusion sonogram, where we fill the uterus up with water so we can look inside and make sure there's nothing hiding in there that could be causing a problem. And also, a lot of people, when they're doing sonograms, they're just doing 2D sonograms. We typically do 3D sonograms, and that's where you can really assess for things like a septum or problems like that. Can
on the saline infusion sonogram, she's saying we don't do it all the time. So if you're one of our patients and you're not getting 3D ultrasounds, we did it, but probably on your saline infusion sonogram. But and you know, it's kind of amazing. For example, I had a patient that I just did a hysteroscopy on last week, and it was an adhesion, and we did her saline infusion sonogram, and we're looking at it. It doesn't look that impressive on ultrasound. On the saline infusion sonogram, she's like, well, won't that band just pop? I mean, come on, let's just do the embryo transfer. Like, she was really frustrated, you know? She's like, I just want to move forward. And I'm like, no, we got to go in, remove it. We do a small procedure called a hysteroscopy where we put a camera in and we actually cut that band of tissue that's like it's basically sort of like a rubber band going across your uterus. Once I got in there and was able to see it with the camera, it was a really thick adhesion. I mean, definitely so glad that we removed it. But it's interesting, even like polyps, sometimes we see them on the saline infusion sonogram. We're like, yeah, it looks like you have polyps, you know, like we're going to go in, and then you get in, you're like, oh my gosh. So you never really know how big of a difference it's going to make until you can see it really specifically with the camera.
Yeah. But I think the amazing thing about all of these that we just mentioned is they are typically easily treatable. So again, similar to what we were talking about with the genetics, you now have information. Information is power to take those next steps to help you when you try again.
Absolutely.
Okay, the next one is maybe hormones. So there are some hormones that we can check sometimes that can contribute to miscarriage. So checking the thyroid, checking your prolactin level. And these are hormones that if they are abnormal, that they can be affecting your menstrual cycle and they can be affecting the pregnancy as well. So those are just an easy blood test for us to do. But I will say a lot of times those things may have been checked before they make it to us, right?
Right. Yeah, I do see, you know, someone who's seen their OBGYN usually gets that checked. I will say we do keep pretty tight control on thyroid for our patients. And so if you're just a woman walking around in the everyday world and you're not trying to conceive, your thyroid hormone cutoff is actually not quite as tight as what we do for our patients that are going to get pregnant and go through the first trimester of pregnancy. So that is something important. You may be a little bit borderline, and then we're probably going to put you on a medication.
Yeah. And then we know that the immune system may be involved in certain miscarriages. And so one of the main ones that we would typically test for is a big long name, antiphospholipid antibody syndrome. And because it's such a long name, we give it an acronym, APAS. Much easier to say, APAS. And so we usually test for this by testing different types of antibodies that we see in the bloodstream. And this is one that is typically more associated with late miscarriages, okay? Because the thought is that with this disorder, you can be more prone to getting maybe tiny little blood clots in the vessels that may feed the baby. And so sometimes the baby wouldn't be as vulnerable to that until the pregnancy is later along, like maybe 10 to 12 weeks or so.
Absolutely. So this was reminding me, I had another question for you. So I was thinking about this other case that I had. I have a patient went through testing for this. So antiphospholipid antibody syndrome, it's blood testing like she's describing. And then we also use clinical diagnoses to put the diagnosis together. Maybe you've had a prior history of a blood clot, or you had a pregnancy that you went through and you had problems that complications of the pregnancy that are indicative of a similar problem, or you had a loss greater than 12 weeks. So we actually use this clinical criteria to diagnose it as well. But I find a lot of my recurrent pregnancy loss patients, even true ones, you know, they're negative for the testing, right? And then you're kind of like, where are we now? Have you ever had a patient who she had the placenta looked at afterwards and there were clots, but tested negative for antiphospholipid antibody syndrome? And how do you manage anticoagulation with the next pregnancy? Because I think that's a little bit of a gray area. I'm curious what you do.
I know. I do think that is a hard situation. And sometimes if I'm unsure, I feel like it's never wrong to just get another opinion. So sometimes I'll have my patients see a maternal fetal medicine specialist, an MFM, to get some advice from them. In cases like that, sometimes I've had them say, oh, well, maybe just next pregnancy, have her take a baby aspirin or something, just a little bit of a blood thinner. I haven't really had any that come back where they say, hey, they need to be on full anticoagulation with Lovenox or anything like that. But I think it's definitely a good question and probably something that we're just still learning about in our field, probably something that needs to be researched further still.
What do you, sorry, I'm like asking all these questions. What do you think about doing Lovenox, even though a lot of the studies were really done with heparin? Do you ever prescribe heparin for patients? This is something, Jason Fernasiak was always really big on this. He's like, look, we really don't have a lot of data about Lovenox, but we all prescribe Lovenox. I'm just curious if anyone out there still does it.
It's a good point because I've heard that some people say that heparin in and of itself may have some anti-inflammatory effects that maybe Lovenox doesn't have. And again, because we don't have the data, but I think it's so hard with heparin because you typically have to dose it more frequently, whereas Lovenox is just once a day, and heparin may have higher risk of certain side effects or illnesses that you can get, whereas Lovenox seems to be safer.
We should clarify heparin and Lovenox are both different types of blood thinners. Heparin's sort of an older medication that was all they had to use that was safe during pregnancy, but then now we've gotten more advanced with our medications. Lovenox is a more recent blood thinner that everyone's kind of switched to using.
But back to APAS, let's say we find out that, yes, you have this immune condition. It's an acquired condition. It's not necessarily a genetic condition. This is acquired. So, and I think this brings up a good point too. Even if you've been tested for it before, sometimes you can turn positive for it later. But anyways, the treatment for this is to be on a blood thinner. But I think that's kind of what you're alluding to there is should you be on heparin or Lovenox? And I think that's kind of where textbook answer is probably heparin. But real life answers, most people are getting Lovenox for convenience and safety. So,
what do you think about patients who have present with recurrent pregnancy loss and they get tested and they have just isolated findings, positive lupus anticoagulant? I see a lot of these patients are put on aspirin and Lovenox, things like that. How do you think we should be managing these patients? This is one of the things I know we've talked about. I'm always so worried about putting people on blood thinners when maybe it's not indicated, but I'm curious.
Yes. I think what Dr. K is really referring to is we have these criteria. So, for example, to test positive for the antibodies, you need to be positive on them 12 weeks apart, and because I actually have to retest it. Sometimes these antibodies can change over time.
Can't be pregnant during your testing, can't have an active blood clot during the testing, just so y'all know.
And so it's hard because what if you were to be positive on one but not the other? Does that mean you totally discount this and say there was nothing to it? And again, I do feel like that's sometimes where I consult with my maternal fetal medicine colleagues too. And I just say, hey, can you give me an opinion on this? Because this is a kind of intermediate case here. I don't want to do the wrong thing for my patient. So sometimes I'll just get an expert opinion on that too. But
That's nice to have backup.
It is. I know. I use my maternal fetal medicine colleagues all the time. They're the best. Okay. And then I just wanted to touch on the fact that we talked about a lot of the more common causes, but here's the hard part. When we do this testing, 50% of the time, recurrent miscarriage is unexplained. Oh, so that's so hard, right? Because, when I've done this testing on my patients, which is kind of a full blood panel of lots of tubes of blood, and they've done the saline infusion sonogram, and then I say, it's all normal, and it's kind of hard. Do you want something to be wrong or do you not? It's so many different feelings, right? But I think one of the really amazing things too is that even if we can't find out what's wrong, there's still so much hope. Okay. Because I had asked the question at one point, and I think maybe we've talked about this before too, is how many miscarriages does somebody have to have before you say you should probably stop trying? Okay. And I looked at a study where they showed women who had 5 miscarriages in a row, if they just tried one more time, their chances of having a baby were 50% with the next one. And that just kind of blew my mind because if somebody would have asked me to guess or estimate, I would have said their chances were maybe 5%.
Right.
And so I think that is the good news that we can give to patients is, yes, we should do all the testing that we can and try to treat what we can. But at the end of the day, too, if you have it in you, let's keep trying together. And I do have some kind of special treatments that I offer my patients too. We can probably talk about that in another episode too, is maybe all the different treatments that we can offer, even if it's unexplained recurrent pregnancy loss. So I think that's the message I really want to give, is a message of hope too.
Right. Yeah, definitely don't give up. In the moment, it does seem really frustrating, but it's even, I mean, I always tell my patients, and this is hard to hear too, the month that you have a loss, there is some data to say the very next month you have a pretty high chance of having a pregnancy that's going to go to term and be healthy. So I always say, just, if you have it in you, try again next month, you know?
And I think too, that's really amazing how things have changed with that. Many years ago, after somebody had a miscarriage, doctors used to tell people, you need to wait 6 months to let your body heal before you can try again. And luckily, there were groups of patients that did listen to us and they got pregnant, and they did studies on them, and they said, oh, you don't have to wait a certain period of time before trying again. If you emotionally feel ready, then physically your body will be ready. And I think the other way we can really support patients, even if we can't help you find a reason why, is when you get pregnant again, we are there to really follow that pregnancy very closely for you. So some patients have told me like, hey, I just feel like, I don't get to know what's going on. I want to know, what are my pregnancy hormone levels? I want to have the earliest ultrasound I can to make sure everything is okay. And we offer those things. As soon as someone calls with a positive pregnancy test, we're sending you to the lab to get blood work done. We repeat those levels to make sure they rise like they're supposed to. And then we scan as early as 5 weeks and 5 days in order to really be able to give patients as much reassurance as we can.
Right. I think early pregnancy monitoring makes a difference.
Oh, for sure.
I really do.
Yeah.
I have patients actually that have seen me just for that.
Yeah.
They actually had a miscarriage, got pregnant on their own, come to see me. They're like, hey, can I just do monitoring with you? I want you to monitor my levels, make sure I don't need to be supplemented with anything, and do my pregnancy ultrasounds. And I think it makes a difference. It eases you.
And I do feel like this is probably something we should advocate as a whole for the whole medical field, because I think standard right now, and this is often led by insurance, is that a patient, when they call with a positive pregnancy test, has said, okay, come in when you're 10, 12 weeks pregnant or something for your first visit. And I understand why insurance companies want to do that. That's cheaper for them. But as women, I feel like we deserve care right away when we find out when we're pregnant. We need to know, is everything looking good? Right. Do we have signs of a miscarriage? Could we have an ectopic pregnancy? These things need to be picked up earlier.
100%. I've always thought that's strange. Even myself, like I've had a pregnancy and I'm like, they won't get me in. I can't get in until, whatever. I'm like, what? Yeah. And really, that's kind of a high risk time for the pregnancy, right? Ectopic pregnancies can be picked up during that time period much more, urgently and early, so that you don't end up having more complications later.
Yeah. And then I did want to just touch on one more thing, which is, let's say you're a patient, you've had recurrent losses, you're pregnant. Sometimes you just can't feel the joy anymore because you've been hurt so much before, and your brain tells you it's just going to be another miscarriage. Like, don't get excited and everything. And, I've actually had some patients that taught me how to kind of feel about this. And here's what I mean is, first, I've had patients who try to say, I'm not going to get excited. I'm not going to get excited. That way, if I miscarry, I won't care.
Right.
Okay, that doesn't work.
Yeah, everyone gets excited.
Nobody ever has been like, oh, a miscarriage, well, I didn't get excited, so don't worry about it. Yeah. No, even if you tell yourself not to get excited, you're going to be upset.
Right.
So that strategy doesn't work. But second, and somebody pointed this out to me, it's so true, doesn't every baby deserve to have someone excited about it, even if it doesn't make it all the way?
Right.
And I was like, that's so true, And
it's our nature as women. Like I said, your brain is just, already thinking about this whole life for this child that you conceive. So.
Yes. Yeah. And so I say, even if you've had losses before, it's okay to get excited. It's okay to be vulnerable. And at the end of the day, could we have pain? It's true. But unfortunately, they say grief is the price of love, and we're going to be there to go through that with you together. So.
Absolutely.
Okay. All right. Well, thank you guys. Hope you have a good rest of your week, and we'll see you next time.
Bye.
Bye.